Well, again, thank you all for joining us this afternoon or perhaps still this morning, depending on where you may be joining us from. We are excited to have an incredible panel of experts joining us today, and we will go into some introductions briefly, but wanted to just quickly introduce myself for anyone that I have not had the opportunity to engage with or interact with yet. My name is Marianna Raia. I'm the Associate Director of Programs at Expecting Health, and I'm joined today by Karla Dawson, Program Manager at Be the Match. And we are honored and excited to collaborate with this amazing panel to really dive into a conversation that we know is very relevant to the sickle cell and newborn screening communities today, and just really look forward to an open discussion. At Expecting Health, we have hosted a number of casual conversation and challenging topic webinars. And what you will find today is that we recognize and understand that we have a very, very diverse audience that is joining us today, coming from all different aspects of newborn screening, the sickle cell community, research, students, et cetera. And we know that this is a great way for each of us to learn from one another. So while this conversation can be challenging, and we know that each of you is coming in with different perspectives and experiences with this topic, we hope that through the learned and lived experience of our panel today that we can really share more and raise awareness and really deepen our understanding. So I'm looking forward to learning from each of you. I know I have a lot to learn myself. So with that, please, we invite each of you who is listening in, if you do have questions or comments as we're progressing through the discussion, please do feel free to use the chat box. We will have time dedicated at the end of the webinar to address, if time allows, any questions that are shared in the chat box. And if for any reason we don't get to all of the questions by the end of the webinar, we will collect those and share those with our speakers in hopes that we can get responses to you all. So to just set some groundwork of what we hope to cover today in this conversation, we're looking forward to learning a bit more through some questions and dialogue with Dr. Olson, just about some general overview and approaches to transplant as a curative treatment for sickle cell disease today. And as you will learn from his introduction, he is extremely experienced and has a wealth of knowledge that he'll be able to share with us on that topic. And then again, through our lived experiences of individuals who have reflected on, experienced, and been a part of families making the decision to proceed with transplant as a curative option for sickle cell disease, we will really learn and deepen our understanding of those experiences. And we hope to leave each of you today with a specific action that you can think about taking. Our goal today really is to have a conversation so that each of us is more aware and more knowledgeable about this topic. Our goal today is not to give guidance on what the right treatment is for you. And so we really want to just open this dialogue up and thank our panel very, very much for being willing to share your experiences and be vulnerable in this context. So with that, I am delighted and extremely excited to turn it over to Ms. Karla Dawson, who has been a partner in developing and coming up with this webinar, and really who has a passion for this topic through her work at Be the Match, but also just at a personal level. And so I'm excited to turn it over to you, Karla, who's going to facilitate just a conversation with Dr. Olson.
Thank you, Marianna. As Marianna mentioned, my name is Karla Dawson, and I'm the Health Equity Program Manager at Be the Match. And I'm so excited to see all of you online today and to be joining on this platform with Expecting Health. For those of you who aren't familiar, I just wanted to share a bit about who Be the Match is and why we're here. So we are a nonprofit organization, and our mission is to save lives through cellular therapies. And specifically, we serve individuals with blood cancers like leukemia, lymphoma, or blood disorders like sickle cell disease to get to and through transplant or other cellular therapies. And we do this in a lot of different ways. And those who may have heard of us a little bit probably think of the bone marrow registry, and we do a lot of work to grow that registry. But we're also providing lots of free resources for patients and families as they navigate their care journey. We're doing research to learn more and advance treatments. We're participating in legislative advocacy to expand and protect access to care. And then we're doing education sessions just like these. Next slide. And so I work on the Sickle Cell Warrior program, and that program focuses on increasing access for individuals with sickle cell disease. And again, we're doing a lot of awareness there. We have lots of resources to educate individuals with sickle cell disease and their loved ones. And we want to try to address barriers people may be facing in accessing, or even just trying to learn about what options might be available for their treatment. And that's why I'm really happy to be in this conversation, because we've heard so many times that no one told us that this was a potential option, or we're having a hard time getting information, or even we wish we had learned about this sooner. So to help us get started in this conversation and lay a bit of the foundation, I'm happy to introduce Dr. Timothy Olson. Dr. Olson is an attending physician at Children's Hospital of Philadelphia, where he serves as the medical director of the Blood and Marrow Transplant Program, the Bone Marrow Failure and MDS Curative Therapies team leader, and the co-director of the Sickle Cell and Red Cell Disorders Curative Therapy Center. Dr. Olson is also an associate professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania. So welcome, Dr. Olson. To start us off, one, you can share anything that's relevant to your introduction that you want to give to this audience. And then could you just tell us a little bit about how transplant works to cure sickle cell disease?
Absolutely. Thank you very much, Karla and Marianna, for inviting me to this session. I am very excited to talk with all of you, and would like to emphasize I would like this to be as conversational as possible. So I've taken the route of not having a slide deck to go through because of the fear that that might get us off of the types of things that this audience most wants to hear about. So that introduction was spot on, and I think particularly relevant to this topic. I am one of the co-founders and co-directors of what we call our Curative Therapies program for sickle cell disease and other red cell disorders that we established at CHOP about 4 or 5 years ago now, with one thing in mind. So when I started in this field about 15 years ago, for patients with sickle cell disease, there weren't that many options for treatment and for prevention of severe complications of the disease. There was hydroxyurea, there were chronic red blood cell transfusions, and then there was matched sibling donor bone marrow transplant for patients who had that as an option. But unfortunately, only 15 to 20% of patients with sickle cell disease would have that as an option. Fast forward to now, where there has been an explosion of research leading to new options for treatment with patients with sickle cell disease, not only disease-modifying agents that are not necessarily curative, but provide other ways to help control the symptoms of the disease, but also an explosion in curative therapies. So not only can we do matched sibling donor transplant for sickle cell disease now, we can use NMDP registry-based donors for transplant. We can use half-matched family members for transplant. And the newest kid on the block is we can now do stem cell-based gene therapy, all of which are designed to cure sickle cell disease. So with this increasing complexity of options that we may have to try to treat patients with sickle cell disease, this really came with a need to better educate families and as to what the options are for treatment, what are the differences between them. And this is why we established the Curative Therapies Center here, where patients and families can come, have a visit with a hematologist, a transplant expert, a fertility specialist, social work, psychology, and then other subspecialists as needed to try to figure out what are the various aspects of curative therapy that are most important for their child and try to get them to the right curative therapy.
Thanks, Dr. Olson. You outlined a lot of the various types of treatments that are available. I was wondering if you could speak a little bit more to how does a cure work for sickle cell disease? I know it's similar across the various transplants and gene therapy.
That's a very good question. And there are some interesting differences between how a traditional transplant works to cure sickle cell disease and how gene therapy works to cure sickle cell disease. So with a transplant, what we're doing is we're replacing the bone marrow stem cells of a patient with those of a donor. And the idea is that the donor may have no connection to sickle cell disease whatsoever, or the donor might actually have sickle cell trait if it's a brother or a parent. And the idea of this is to remove the patient's own bone marrow stem cells and replace them with the donors. And if this takes and it keeps, and the patient remains 100% donor in their bone marrow stem cell compartment, then what this means is that patient will no longer have sickle cell disease because sickle cell disease is caused by a mutation in the beta globin gene, which is one of the two genes that produce proteins that produce hemoglobin, which is the main protein in red blood cells. You need hemoglobin to carry oxygen throughout your body. And in patients who have the beta globin mutation that causes sickle cell disease, that hemoglobin in those red blood cells become unstable, become misshapen, and cause damage to blood vessels as they go around the body. And so by replacing those bone marrow stem cells, you're replacing the red blood cells with red blood cells that don't have that reaction. They don't form the sickle cells, and they stop causing that damage to blood vessels, which leads to all of the problems in sickle cell disease. So with a traditional transplant using a separate donor, that's how the cure works. In gene therapy, we take the patient's own stem cells and we partner with companies that have developed technologies to either insert a healthy copy of the beta globin gene into those same bone marrow stem cells, but this time the bone marrow stem cells are from the patient themselves. And that dilutes out the sickle hemoglobin, if you will, and allows you to have enough normal hemoglobin that it makes it much less likely that you would develop those sickling complications that lead to the disease problems in patients with sickle cell disease. The other form of gene therapy that is being studied is reversing a molecular switch using a technology that's known as CRISPR-Cas9. And what happens in that form of gene therapy is there is a targeting of the DNA to knock out an element of the DNA that causes baby hemoglobin to switch off and adult hemoglobin to turn on. By doing this CRISPR gene therapy, again, in the bone marrow stem cells of the patient, what happens is that the adult hemoglobin turns off and the baby hemoglobin starts being produced again. And it turns out that baby hemoglobin in sickle cell disease is normal. And so this again dilutes out the sickle hemoglobin, increases the baby hemoglobin or the fetal hemoglobin, and that allows patients to become symptom-free from their sickle cell disease. So these are different forms of cures, right? Because in gene therapy, there is still sickle cell hemoglobin around. It is just diluted out to the point where the red blood cells don't become damaged and take that sickle shape. And so you don't get the manifestations of sickle cell disease because of that. Whereas with an allogeneic bone marrow transplant, meaning you're doing a transplant from somebody else's bone marrow cells, in that you're fully replacing the blood and immune system with that of the donors. And that's why the patient doesn't develop any more complications of sickle cell disease.
Thank you for that explanation. As questions come through the chat, we'll let you know.
Okay.
One of the things that did come up as people were filling out the registration was who's eligible. So we're just curious as to what are the current guidelines for a curative therapy like transplant?
Absolutely. That's another great question. And it's something that has evolved a lot over time. So when I started taking care of patients with sickle cell disease and being involved in curative therapies, really the only patients we considered candidates for curative therapy were those who had a sibling who was a full HLA match. And again, as I said earlier, the likelihood of that is only about 15 to 20% across the population of patients that have sickle cell disease. Every sibling, full sibling, meaning same mother, same father, has about a 25% chance to be a match with a patient with sickle cell disease. And that sibling could have sickle cell trait, or they could be completely unaffected by the sickle cell change. Back when I first started, to be eligible for the transplant, even if you had that matched sibling, you had to have shown that you had had severe complications of sickle cell disease over the years, right? So the patient would have had multiple episodes of acute chest or multiple episodes of pain crises requiring hospitalization, perhaps cerebrovascular disease, which means the blood vessels in the brain were significantly damaged. So you had to have had those complications to be eligible for curative therapy. Now, what has changed is that we've gotten very good at doing those sibling donor transplants for sickle cell disease. And now it's become almost a universal recommendation that as long as you have a severe genotype of sickle cell disease, meaning that you have SS disease, or in some cases SC disease, S beta 0 disease, you are eligible for a transplant if you have a suitable matched sibling donor, regardless of your complication history, because we know the lifetime of complications that patients with those genotypes of sickle cell disease will have without curative therapy. We anticipate success with sibling donor transplant in over 95% of the transplants now. That's changed a lot since when I started 10 to 15 years ago. And because of that, any patients with those severe versions of sickle cell disease, we would consider to be eligible for transplant. Now, if you don't have a matched sibling donor, we still require a history of significant sickle cell disease complications to be eligible for either what we call the alternative donor transplants, which are either using a registry-based unrelated donor or using a partially matched related donor, or to be eligible for gene therapy. And so to be eligible in that situation, you had to have had a history of at least a few episodes of acute chest syndrome, severe vaso-occlusive crises, perhaps the cerebral blood vessel disease as well. But as we go into the future, I think as we get better and better at those forms of transplants, I think that requirement to have had that severe disease history may drop with those types of transplants as well.
Thank you for that. I'm going to turn it over to Marianna and get to introduce Kisha and Andrea. But one last question, if you could just briefly talk about some of the barriers you're seeing right now for people with sickle cell disease accessing a curative therapy.
Sure. So the biggest barrier is an available option right now, but this may be something that could change tremendously over the next 6 months to a year. To be eligible for allogeneic transplant, you have to have a donor that we can identify, right? And we talked about only 15 to 20% of patients will have a sibling donor. To find a registry-based donor, generally patients who are of the ancestries that patients who have sickle cell disease are of. So those are patients of African descent, of Middle Eastern descent, of South Asian descent for the most part. There is only about a 20 to 30% likelihood of finding a full 10 out of 10 match in the NMDP registries. And so historically, that's where we started with offering unrelated donor transplants for patients with sickle cell disease. More recently, in the last few years, more and more studies have looked at doing curative transplants using closely matched donors. So rather than being 100% or a 10 out of 10 match, we're now using donors who are 9 out of 10 matches. And that expands the available donor pool tremendously for patients of those ancestral backgrounds, such that over 70% of patients will have a usable 9 out of 10 donor in the registry. And so being eligible for one of those treatments that allows for a 9 out of 10 donor has expanded access and availability significantly. The risks of that type of transplant, though, are probably a bit higher than the risks of using a fully matched transplant. Where things are going to change a bunch, we anticipate in the next 6 to 12 months, is there are a couple of companies that are going to the United States government and seeking approval for their gene therapy technologies. And those approvals could be in place if they are successful by the beginning of 2024. And if that's the case, then gene therapy could greatly expand the access for patients with sickle cell disease, provided that insurance companies are willing to pay for the gene therapy once it is FDA approved, once it's approved by the government. And so this is something that we're looking at very closely going into the next year, and could be a game changer in terms of access to therapies for patients who don't have well-matched donors.
Thank you. Marianna?
Thank you both so much, Dr. Olson. That's such an incredible foundation for going into this conversation, and we knew that would be important. I am thrilled to introduce Kisha Hampton and Andrea Matthews, and I will keep their introductions very brief, as I know they have a lot more to share about their individual experiences. But as we were brainstorming this idea and really focusing in on the importance of having this discussion, we recognize that we're in this really interesting space of evolution of technologies, of treatment options that are available for sickle cell, but that are also concurrently happening within the newborn screening system. And while we know that newborn screening is certainly a significant way that many families first learn about a diagnosis of sickle cell disease, we're also concurrently hearing that transplant doesn't really get discussed as an option for the reasons Dr. Olson laid out clearly until much later in an individual's journey. And so we really wanted to bring to this conversation two individuals that have worked personally or directly with families who have walked this decision-making process, who have, and I already see questions in the chat about preparation, who help families prepare for making this decision and completing or going through a transplant. And so I'm thrilled to introduce again Ms. Kisha Hampton, who has over 25 years of experience working directly in community-based services and education, and who has spent, I believe, close to the last 15 years of her time leading the sickle cell team and coordinating outreach to families at the Indiana Hemophilia and Thrombosis Center. And we also have joining us today Ms. Andrea Matthews, who is the mother of a child with sickle cell disease, who is the founder of the Children's Sickle Cell Foundation, who has served as a family representative to the Health Resources and Services Administration Advisory Committee on Heritable Disorders of Children and Newborns and Children, and who's currently the executive director of the Brashear Association. So both of these women have extensive experience in this journey, and I would love to just kind of first ask both of you, Kisha, I'll ask you to share first, to just, kind of share a little bit more with us about yourself, about your role within this conversation and your experience with transplant.
Okay. Thank you for allowing me to participate on the panel. Again, great discussion, Dr. Olson. I've been involved with newborn screening specifically all my career, here in Indiana. And one of the questions that I would sometimes get after, providing the home visit, that includes like education and detailed information about, antibiotics and, pain and things like that. I commonly sometimes get the question, is there a cure? Or I heard there wasn't a cure. And I kind of think that introducing that, or at least letting the parents know, regardless if their child has would qualify or not in the future, letting them know that bone marrow transplant, is, a cure, for sickle cell disease, but also letting them know that it's not a cure for everyone. It's not, 1, 2, 3, as I would put it, to them, to kind of break it down on their level. And I think it's important for parents to know that, because I've run across my career, I've run across so many families who this child that they have now that's diagnosed with newborn through newborn screen with sickle cell, before that child, this family may have like 3 children that are all full-blooded siblings. And I've seen a few times, unfortunately, here in Indiana, where that child grows and grows and grows, and that hematologist may not ever tell that parent, well, or ask that parent, are these siblings full-blooded? Can we do HLA typing? Because, there could be a cure. So I think kind of, denying that family that information, and even that test, it's just a simple test of, bringing all the family members in, let's see if anybody's a match, and they may get lucky. We got lucky here, and, a mom decided to have testing for, she has 2 children with sickle cell. She decided to get the HLA typing, and the older brother matched both of them. Perfect match. So I think you don't want to give parents hope, that, I can do this and it's definite I can do this, but I think that they should also be empowered to know that it is an option. And with gene therapy, when I heard about that, it's like, this could potentially be something for more people. So, it's all exciting to know that, children, they can get that diagnosis initially, but they may not have to have this, their whole life, and, deal with all those compounding problems that, can occur as they grow older and, become an adult. Did I answer all the questions?
No, thank you for that. Yeah. Absolutely. Andrea, go ahead. You want to introduce yourself a little bit more, and would love to kind of hear your experiences with transplant.
Okay. Hi, everyone. Thank you so much for the invitation to participate in this conversation. I think it's very timely as we're getting ready to celebrate newborn screening and sickle cell awareness month. So I would just like to say that as a mom of a now 23-year-old, I was living in the time where Dr. Olson talked about, wherefore the options were very few. And so Jonathan was born in 2000. And one of the things that everyone wants to do when they give you the diagnosis is to give you some hope. So the hope is very important to share. But as we're taking in so much information at that moment, as you were talking, I kept thinking, among all of the information that you need to know about this decision and all the emotions that are involved, because now you're perfectly happy baby, you're looking at them now like, oh my God, what's going on? So you're taking a lot of information in as a parent and trying to sift through it. Hearing that there's no cure is the first thing that I think reverberates in your ears, like, oh, there's no cure for this. Oh, and it's painful, right? You're gonna, bracing yourself for years of pain. And of course, if you were like me, I went directly to the internet, and at that time, the internet was filled with very scary things and not a lot of support. So, when the conversation turned to, not having a cure, this is, there were some options, very few options at that time. We began to, start his regular medication, but then he became sick. And so he had acute chest twice a year, every year from age 2 until age 6. And that was when our doctor came to us and said, he's having acute chest syndrome twice a year every year. He's having pneumonia twice a year. He's having pain crisis. He has a severe outlook, and we need to do something. And so that was the first time that we had talked about bone marrow transplant. And having been, I knew nothing about it. I was like, oh my God, what in the world? And so what is it? What is it? How has it happened? What do we need to know? It was very scary. And we had to have several conversations. It wasn't one. It was the first conversation, introducing it, talking about what the options were, looking at, John has 3 full siblings, so he's the youngest of 4. And it was kind of a no-brainer for me. I kept thinking, yeah, this is it. You know, we can now stop spending 6 days, a pop. Every time we went to the hospital, had a hospitalization, it was 6 days, 6 days away from work, 6 days away, it was terrible. And so this life that persons with sickle cell disease, children, are faced with is painful. There's many hospitalizations, and I really just wanted it to go away. And so I thought, let's talk about it. So our doctor was very cautious and, explained everything. We had, I think, 3 or 4 conversations over several months to make sure that I understood the process, understood what was going on, and also understood that it wasn't a guarantee. Even if we had said, yes, we're going to do this, move forward, had the typing, and if everything went really well, you still didn't, at the end of the day, it may not work. So it was a lot to take in. But over all the conversations, we did decide that this was the path that we wanted to go on. We understood that it was our own decision, that it was ours to make, and that we had some things to think about. Or we, thinking about, his long-term life, what it would be post-transplant if it really did work, being sickle cell free. At that, those were some of the hopeful ideas, but the path of having him, prepared for the transplant, that part was a little scary. And at that time they were doing full ablation, so we were like really, nervous, but we still decided to go ahead because we wanted that to be our solution. We wanted it to be our cure. And so all 3 siblings were brought in very young, and they understood. And even my son above John, he said, do I have something that will make John better? And I thought that was really sweet. And I don't know, we don't know, but we're going to get tested. And so that helped him sit still for the needle stick, right? So he was very happy about that. At the end of the day, we ended up finding out that none of them matched enough. And it was devastating. I literally cried. And I said, how can this be that we don't have this, And so hearing, that only 15 to 20% of people have this match, it makes sense now. So I don't remember if that was explained, but it probably was. So having to deal with that and cope with that, and then having the fallback of, okay, now that this is not an option right now, I remember Dr. Krishnamurti saying to me, when he was first born, he said to me, a cure could come in his lifetime, maybe in the next 20 years. And so I kept thinking about that. And it had been a couple of years since I had heard him say that. But I said, okay, so this isn't our cure, but a cure is coming. And so everything that I've been able to do to talk to parents, to help them with the decision-making process, it is a family decision. It's something you don't want to make on your own. Even the decision to take hydroxyurea, which I thank God for hydroxyurea because it changed the trajectory of our lives. And we from the time he started it when he was 6 to now, he has had very few pain crises, and he's doing very well. So I think about that, and I think about how it extended the game. All of you basketball fans out there, extend the game, stay as healthy as you can possibly be, because when the cure comes, whether it's bone marrow transplant, whether it's stem cell transplant, and I've been educated today about some of the things that I'm going to go back and talk to my now 23-year-old to say, this is your decision, right? Mom has gotten you to a certain point, but now he gets to make the decision on what he wants to do for the rest of his life to stay healthy and to be informed about what options are there. And I'm going to put a plug out there for sickleoptions.org, because there are many options. And if you're a family out there, if you work with families that have sickle cell disease, it's an amazing website that can help families work through the decision-making process. So I will stop there and just say thank you so much for letting me share a little bit about our story and where we are right now. But it's very important that families get the support that they need to make the decision that they're going to be able to be comfortable with today and 10 years from now and 20 years from now.
Sorry, absolutely, Andrea and Kisha, thank you both so much for sharing that. I think your journey, specifically, Andrea, really highlights that this is not an easy decision that gets made quickly, and there's a lot that goes into the process, and a lot of education, awareness, and discussion that is happening to get to a place where you feel comfortable with the next steps, and that changes over time as well. We're going to come back to staying informed, because I think that's a really important and really highlights kind of the purpose of this webinar today. But I did want to come back to some of the questions in the chat. I think Dr. Olson, some additional context that may be helpful for this discussion is just given what we know to be some of the barriers to even qualifying for a transplant. How often are these types of curative treatments happening? Can you maybe elaborate a little bit more on just how often you're seeing this, and speak to that a little bit?
Yeah, that's a great question as well. So when I started, go back to 2008 or so, we might do 2 curative therapy treatments, generally matched sibling donor transplants, a year for patients with sickle cell disease, and we're a fairly large bone marrow transplant program in a large children's hospital here. And I think if you fast forward to today, our expectation is that we would consider doing up to 10 to 15 a year with the currently available technologies, knowing that gene therapy so far has been limited to clinical trial slots, and those have been somewhat scarce. What we are projecting once gene therapy is commercially available is that, at our center, we would be looking at treating, up to 20 to 30 patients a year with curative therapies for sickle cell disease, whether it's gene therapy, whether it's sibling donor transplant, or whether it's alternative donor transplant. So I think that, to date, the growth in the number of curative therapies that we have administered has largely been more patients, more families being aware of matched sibling donor transplant as an option, some degree of expanded use of alternative donor transplant with unrelated donor transplants being the primary modality there. And then as we go into the future, I think it may well be gene therapy that drives doing more. That being said, we have this curative therapies clinic, this multidisciplinary clinic that meets at least once a month here. And we see up to a handful of patients once or twice a month who are interested in discussing curative therapy options. So I think the discussions are happening with more and more frequency, and as we have gene therapy to add to our arsenal of possible curative options, I think more and more patients are considering these treatments.
Yeah, thanks for that. So I'm going to shift the conversation just a little bit to thinking more broadly about the timing of these conversations when they're happening. And we have a lot of newborn screeners and individuals who work with newborn screening laboratories and follow-up programs who are joining in today. And even from, I'm going to combine several of the questions from the chat. I'd love to hear from all of you a little bit more about your thoughts on the timing of introducing transplant as a curative option. Is it appropriate? Is it best to do that at the time that a family first learns a diagnosis of sickle cell disease? Is it better to wait? Kind of what are your thoughts and experience on when is the ideal time to discuss transplant as a curative option? And any one of you can jump in on that, because I know you probably all have thoughts. Go for it, Kisha. Yeah.
So I'll start. I think because our program coordinators, and when I was doing the home visiting for the very first visit, I think the most important thing for the parents to understand is that, through newborn screening, this is the reason why we do it, so that we can talk to you early. Your child can get on the penicillin and the antibiotic early and explain why. And then let them know, what pain will look like and when it'll come, and, the difference of, if you have SS or if your child has SC. I think that's the main topic to cover, in that initial visit, that initial education, as well as letting them know that compliance is, very important to keep your child healthy. But I think in most cases, our program coordinators don't go right into letting them know about transplant. That may be, that question may be answered if a parent asks. If you have a parent that once you get to that home visit, they've got 1,000 questions written down, and one of their questions is that, so if that's the case, to let the parent know that, there have been people cured of sickle cell with a bone marrow transplant, but the most important thing now is keeping your child healthy, because that's not even going to be an option right now. So that's what, I've trained the coordinators to do here in Indiana. So, because like Andrea said, all that information at once, the home visit might be consoling the parent about this diagnosis that they had no clue about. So later, if the question's asked, then letting them know that, yes, it is, but not right now. These are the most important things to worry about to keep your child healthy and help them grow.
So I'll add to that. I agree. I think that in the beginning, most of the parents are not seen by the genetic counselors. We go right into hematology, and so we're getting this information from the genetic counselor who's either in that practice or through one of the nurses or nurse practitioners. I think we have to see if the child is going to do well, right? And so with hydroxyurea being given and available at 9 months, we're finding that these conversations can happen later. I do think that it's overwhelming to get all of the information all at once. And I think that because this is something that they might need to think about in the later to see, if they're going to have a severe course or if they're going to be even eligible from that standpoint. I just think later is better. And I think that not trying to overwhelm the families with every option, because now there are so many. I think a little bit at a time is good. If they do ask, that's fine. But I think that for the most part, we need to see how well they're going to do, because no two sickle cell patients are alike. No two courses are alike. And it's really an individual family decision.
I think both Kisha and Andrea's comments are spot on. The only thing I would add is, differentiating between us, pushing the information about stem cell transplant on patients and families who are coping with this new diagnosis. 100% agree, we shouldn't do that until they are, up to speed with everything that is happening. I think there are going to be families that, from the moment they have this diagnosis, are going to be asking questions about curative therapy. And I think for those patients, we should certainly be willing to offer that information if they are asking about it. I think the earliest we would typically think of doing a sibling donor transplant, if there is a sibling option, really wouldn't be until after 1 year of age. There are some centers who will not do it until at least 2 years of age. And so, knowing that, you certainly have time to adjust to this diagnosis. I do think in the providers' minds, one of the things that should be in their minds when they first see a new patient with sickle cell disease is to make sure they're asking the question, okay, do you have, does this child have full siblings, meaning same mother and same father? Because in the back of the provider's mind really should be that by age 2 or so, if there are full biological siblings, HLA typing should be done. If the patient has a sickle cell disease with a severe genotype. And that conversation, what I would suggest is that conversation about matched sibling donor transplant should be had by the time that the patient is 2, so that HLA typing can be there. And the reason why it's helpful to have it early is if you don't have a match, there are families that may consider options such as in vitro fertilization with pre-implantation genetic testing. And knowing, the information about an existing match could inform reproductive choices as families go forward. And, waiting 10 years, families may be at a very different place in terms of considering having more children than they might be waiting 2 years after a child is born.
Dr. Olson, those are great points. And there's actually a question in the chat box that was asked a little earlier on, specifically around cord blood banking. So I don't know if you have any comments or additional, considerations that you'd want to share in terms of discussing cord blood banking when there is, a known sibling with a diagnosis.
Yeah, I recommend it in everyone. If there is a patient with sickle cell disease and the same mother, same father are having another child, there are programs via cord and others that can help with that banking, and we should be banking that cord. That's an easy one from my perspective.
And we should be supporting that. Right now, it's not, that's a huge barrier because it's not covered under insurance. So we need to, there's some insurance implications that also come up. I've had families who have been in that situation and they're like, it's expensive to, to go through those programs. So looking for resources to support that is very important as well, that we address those barriers. We don't currently have anything that could do that right now. Not currently available.
Well, yeah, so, I think Kisha is going to say the same thing that I'm going to say. So go ahead. Yeah.
So one, I'll just have to tell a story. So when our newborn screen program was from birth to 3 years, I go out and do an assessment home visit with a mom, and she's sitting behind the table. I can't see her, so she, so then when she gets up, it's like, oh, we got something cooking in the oven. But she already has like this 1-year-old with sickle cell. So, with every family that we tell families up front, if you and the father become pregnant again, let us know. Don't think of it as I'm trying to hide it because I'm worried if the baby will have sickle cell or not, or I'm trying to hide it. Let us know, because what we do is we will help our families fill out the ViaCord sibling connection application. One part of that application is the medical referral that goes to the doctor. And it used to just list SS and sickle beta 0. Now it even lists sickle beta plus on there. And so we give that to their hematologist. We help them fill out their the other part. And and we just let them know that if you're banking, it's like correct me if I'm wrong, Dr. Olson, they can save the cord blood for 5 years free. But there's another section that the ViaCord tries to save, which is the pay component part. So we try to explain that to parents that you don't want that part, you want the cord blood part, so that when the hematologist is ready to, that child's born, they don't have sickle cell, the hematologist can request a sample from that, as well as do the HLA typing to see if that's a match. But there is a free portion of that, and it's all like really self-referral, and the hematologist fills out the other program. They send the kit to the mom. You know, if you catch her in time, they'll send it to her to take it to the hospital with her. And the hospital knows exactly what to do. So there is a 5-year free program. You just have to make sure that they're not being charged for that other like tissue, maybe sample part. I mean, clarify that, please, doctor. Thanks.
Yeah, that other part is placental tissue storage, and we don't need that. We just need the cord blood. If the proper paperwork is filled out, there should be very little to no charges incurred by the family for the first 5 years if they do the sibling connection program through ViaCord. Yep.
Super interesting. And I know we're coming up on time. I think we've certainly heard throughout the discussion a number of different barriers, not just to treatment itself, but really even to the information to potentially explain and support transplant as an option. And so I feel like we could have a whole nother hour-long discussion just on some of those barriers and disparities. But as we wrap up here in the next few minutes, I would love for each of you, if you don't mind, to just share one action, one thing that people who are listening into this conversation can do to help support a family, to raise awareness, to really help bring, again, the conversation to the forefront so that we can all be more informed and more aware and better support systems for the families who are going through this as an option. Kisha, you want to go first?
So I would, I mean, I guess when I would say that if, kind of like with Dr. Olson, it's kind of like our doctors here. If we know that the curative therapies are getting better and better, and there are more and more, especially with gene therapy on the rise, I think that as medical professionals that are working in the area, working with people and families with sickle cell disease, to make sure they at least know the information, that, not to say we want to give everybody hope, but at least let them know so that they can actually make a decision, make a decision for themselves, and, talk to their family members about it. So just raising awareness that there are things coming, and some things that are there, and just making sure that they're aware of them and not keeping them, in the dark.
What I'm going to say is somewhat aspirational, and hopefully this sits okay with everybody. But my vision of this, on the cusp of perhaps there being gene therapy being approved, with the advances that have happened in other forms of transplant in the last 10 years, is that a child born with sickle cell disease today, my aspiration is by the time that they're 20, whether it's through a curative stem cell therapy, whether it's through other disease modifying agents becoming available, they should be able to live symptom free from their sickle cell disease. So in these next 20 years, we should be at a point where we have revolutionized what it means to be born with sickle cell disease and to be facing a life with sickle cell disease.
I guess that leaves me. I will say that thank you for all of that. I think that, years ago, we coined the term living well with sickle cell until there's a cure. Like, we really want people to be living well. And so I echo that, with you. I think an action is to go back to find all of those that were not eligible, that might be eligible for the things that are happening now, and really educate them, the folks who are transitioning into adult care, and really look back and see what it is that we can do to help them live their next 20 years living well with sickle cell. So we just need to share a little bit more about what's going on. And if I didn't know there was a free service, man, I feel like I'm out of the loop. But that means a lot more people don't know. So we need to spread the word about all of the services and how we can get support. And I would just like to better connect with all of our efforts, better coordinate the efforts.
Thank you to all of you. Very practical and inspirational at the same time advice. So and encouragement. So I thank each of you, both Karla and I, Be the Match and Expecting Health, really do appreciate, again, your just honesty and transparency in this discussion and being able to come to the table and chat about this because it isn't easy. And, I certainly hope everybody can walk away feeling like they have a deeper understanding and learn something today. So to that end, we invite all of you who have joined us. We welcome your feedback. We would love for you to take a few moments to share your thoughts with us in a quick survey. You can use this QR code to do it. And Andrea also mentioned earlier, I cannot let the webinar end without letting everybody know that September, starting next month, is both Newborn Screening Awareness Month and Sickle Cell Awareness Month. We do have some incredible things planned. Be on the lookout. We have a number of additional webinars planned in the month of September, more information to come through our newsletters. And so we invite you to join us again. Our next one is scheduled for September 5th. And so thank you to each of you, to our panelists for joining us today. Thank you for those of you who listened in. And please don't hesitate to contact either Be the Match or Expecting Health with any follow-up questions. And again, if we didn't quite get to your question in the chat box, I think we did an amazing job. We got through most of them. We'll collect those and share them with our speakers. So thank you all. Have a wonderful afternoon, and we'll see you next time.